of the editing. Like he's the one who gets like bent out of shape because Susan doesn't follow the rules. And also because Susan doesn't talk to the microphone.
No. And there's Susan then.
Yeah.
You know?
Yeah. Okay. Yeah. Okay. We're like an old marriage.
I was going to say that. Yeah, totally.
I know.
Sorry for saying sorry. Media presents the Purr Podcast, the best podcast for feline medicine and surgery with tips, tricks, and updates for the entire veterinary healthcare team. If you're dying to know more about cats, keep on listening. Here are your hosts, Dr. Susan Little, famous cat vet and textbook author, and Dr. Jolle Kirpenstein, talented surgeon and social media geek.
Welcome, everyone, to the next edition of the Purr Podcast. And if you're wondering who this is Serge Chaloub, the actual invited speaker who is introducing you to today's topic. May I introduce you our hosts?
Yeah, Dr. Jolle Kirpenstein.
And Dr. Susan Little.
Yeah.
So Canadians are so easy.
Yes, you did an awesome job, by the way.
You did.
Thank you so much.
Can you come more
Yeah,
often?
do you
our
need a
MC?
gig on the side?
I'd love to, sure.
Yeah. I think you have a perfect voice for this.
That's awesome.
Yeah.
Yeah, he did really well.
He has a great voice.
I think we should, we can pre-tape it. So
yeah, we kind of like
if you stay a little longer, we'll
we'll
have
you do a bunch of intros.
You got it.
Exactly.
I could do that.
There's one problem. The residuals check is very small.
Gotcha.
Sorry.
Exactly.
Not much in
But we do have a
residuals.
PA that can run for anything you want.
Yeah.
Perfect.
Yeah.
Sounds
Exactly.
good. Yeah.
Coffee, we can pay you in coffee.
Yeah.
You know,
So
we
I
got that
think
covered.
now is the time that we officially need to thank our PA.
Yeah.
And maybe you want to take
true.
a...
That's true. So this is the first time we've had a podcast assistant.
Yes.
And you have had the benefit of communicating with our podcast assistant.
Yeah.
Exactly.
Yeah, so this is a good time to thank Ben Javinsky, who just
Thank you.
Yeah, who has been helping us organize podcasts lately, and
Yes.
I've discovered that I kind of like having an assistant.
I bet.
No, normally I'm the assistant, so that's where
Yola thinks he's the assistant. Yeah. Yola has assigned himself
she is
the
a
role.
tough act to follow.
Just
It's just like, where's she now? Oh, she's there.
Don't believe
All right,
it.
so Serge,
Yes.
welcome to the podcast. It's wonderful that you are here.
Thank you so
and
much.
I'm very excited because we're talking about a lot of stuff. Do we want to explain the rule?
Do you want to explain the rule? Okay, we'll tell you there is one rule.
There's rules.
There's only
A
one
rule.
Oh, one.
There's a rule.
Yeah.
That's a rule. And some people are really good at the rule and some people aren't. So the rule is a feline medicine podcast.
Yep.
So there's a word
Cats
you can't
only.
say.
What's that?
It begins with D.
Begin D.
Yeah, D.
Yeah.
D.
D.
Oh, yeah. D. I was like, see, I was already on the cat stream, so I couldn't
Good.
think outside the box there.
Yeah, maybe
so.
we shouldn't have told you.
Gotcha.
So if you do say that word,
Yeah.
Yes.
we keep count,
Yes.
and you owe us a drink for every
Glass of
time you
wine.
say it.
Oh, okay.
Yeah,
Okay.
yeah. So some people are really good at, like Stan Marks. We had
Yep.
on. Stan was amazing.
Was he
found
really?
many different ways
It
not to
surprised us
say.
too.
Yeah, many different ways not to say the D word, and other people just like give up and know to come.
You got it. All right,
Yeah.
I will do my best.
So
Yes.
like no
Yeah.
pressure.
Yeah.
No
So
pressure.
we
And I don't like
expect a
wine
magnum.
anyway. So.
Ah,
We expect a
there.
magnum.
All right, you got it.
Yeah, you don't have to drink it. We
Yo,
do.
gotcha.
Exactly.
Yeah.
Exactly.
Yeah.
Ooh,
Yeah.
get so much wine with Christmas, you know.
I know.
If I think about it.
Yola's all excited now. Yeah.
Yes, exactly.
So I'm particularly excited that you're here because you're Canadian.
Yeah, you're
Mhm.
Canadian.
How many Canadians have we had on?
Quite a lot now.
Yeah, well
Oh, wow.
now.
Now that you've been in
Because
Canada.
because we've been taping in
It kind of
Canada.
helps.
Yeah.
It kinda
So
helps.
tell us a little bit about yourself, Serge, and like how you got your start in veterinary medicine and what you're doing.
You
now.
got it.
Yeah.
Yeah. So I was born and raised in Montreal and went to vet school in French there at the University of Montreal.
Yeah.
Did my internship there, 2 years as an emergency doctor, and then did a residency at the Animal Medical Center in New York,
Ooh.
followed by a renal dialysis fellowship.
Yeah.
And of course, most of our patients were cats. They were
Mhm.
acute kidney injury,
Yeah.
acute renal failure. So that's where I got my career started, stayed there as a staff doctor, and I've been at the University of Calgary's vet school for the last 8 years now.
8 years. Wow,
Yeah.
time flies,
Yeah,
huh?
it flies.
Wow.
It's incredible.
Crazy. So you go from the big
Yeah.
city to
Calgary.
To the
Calgary.
Cowtown?
Yeah.
To the
Cowtown.
Cowtown.
Yeah.
So that's
Yeah.
a big change.
Not the Dogtown. Oops.
Yeah.
Sorry.
Oh,
See
yes.
how easy it is.
Yes.
Yeah. Yeah,
So,
but that is its official nickname, I think,
yeah.
isn't it?
Cowtown it is, yeah.
Yeah.
So
Yeah, it is.
Montreal, New York City, Cowtown.
You got it. That's right.
And how are you feeling?
Feeling pretty good.
You like cows?
I like the Rockies.
Yeah.
I like the Rockies.
Yeah,
It's a beautiful city for that. Yeah.
So, and how far is it from ski area that you are?
It honestly, door to door, 45 minutes, we can be at ski hills, which is fabulous. And we're big outdoor people.
Yeah. So if you're an outdoor person, you like hiking, you like canoeing, you like skiing, you like
mountain biking.
Mountain biking.
Awesome.
Yeah. It's a great area of Canada to live in.
Absolutely.
Yeah.
It
Absolutely.
gets a little cold.
It does, but surprisingly less cold than I find than here in Montreal because there's no humidity. It's quite dry.
Yeah.
So it does snow, it does get cold, but you just don't feel that bone chill.
Yeah, exactly.
Ottawa and Montreal are more humid, and I think it just feels colder, doesn't it? It just seems to bother you more, I think.
Yeah,
but in Ottawa, it's the extreme. It's like really hot and really cold.
It can be. Montreal too.
Right.
Really?
Yeah.
Ah.
Yeah, we can be like plus 30,
like
35 in the summer and like minus 35 in the winter.
Right.
Yeah.
And in Calgary, the summers were usually around 25, 27 degrees, so it never gets to that.
It's actually more moderate climate, strangely enough, on the prairies.
That's interesting. Oh,
Yeah.
Cool.
Well, you're welcome to come over one
of
day.
Of course. No, now I'm coming, and I'm ready.
He's
really.
ready.
And so next to skiing and outdoor, what is your function at the university?
I'm a senior instructor there. So my job there as a tenured professor now is mostly lecturing and mostly clinical work and clinical teaching with a very small research component to it. Yeah.
What do you like the best about what you do?
I love the combination. I love the ability to do both. So 1 week in clinics, 1 week's teaching. It's just a fabulous mix. Really keeps me engaged, and I have a lot of fun with it.
Yeah.
And we get to do a lot of team teaching as well, which is something we've done here at Wasava. My colleague, Dr. Boyes, and I do a lot of team teaching. Yeah. So really it's something to engage the students even more.
Yeah, I think it's more engaging. It's more interesting as an instructor, too. I know when I've done like lectures together or wet labs together, with one or more people.
Team teaching.
Yeah,
you do?
Well,
Did you get any teaching actually done?
That's debatable.
That's a good point.
Ask us tomorrow morning when we're done our
yes.
When
we
we're done
have
our
a lecture tomorrow morning again.
Oh, I'll definitely have to come to that.
Yeah. But it is more engaging. It's more
fun.
interesting too, right, for the instructor.
Agreed.
And you get to mesh different viewpoints and different experiences together. So I kind of like that too.
Exactly.
Yeah.
Exactly.
So is that a bit of a cultural ethos in Calgary too that you guys do?
I have to say the faculty is very open to different teaching styles and wanting to encourage innovating teaching, which is really good. I think the whole university is.
Yeah.
So it's something we started and they've really embraced, and we're able to do it in multiple different classes, which has been great.
Yeah. Calgary's an interesting school within Canada because it operates differently, right, from our other schools.
Yeah.
So it's more on the sort of distributive model, I guess they call it.
You've got it, exactly. For clinical work.
For the clinical work.
And the rotations.
Yeah. So your students are, describe just how that works, at least at Calgary.
So all of their fourth year is done out in the community, mostly in Alberta. Yeah. And they have some mandatory rotations, but again, that they do with the practitioners out in Alberta. So they get to learn right away, in the clinics, and they get to see live real cases. They handle money. They talk about finances. They see real clients. There's no fluff, I guess, in the between. It's just a very different model. There's pros and cons. There certainly are. And now that we've graduated enough classes, we're looking at that model and seeing how we can standardize that teaching a little more. The students do also rotate through us, the specialists, because we practice out in the community in specialty hospitals, equine, bovine,
I'm not sure I realized that.
So you don't have a clinic in the university itself. So where do you do your 1 week, every other week clinic work then?
Yep. So I do it at the care center, which is a big specialty practice there. Okay. So when I'm at the care center with students, I'm part of the university, even though I'm slotted into the cares team. Okay. And it's kind of a win-win-win for everyone because they get an expertise. They have another specialist. And then for me, I have a large private practice case base, as well as students get to learn on the go.
Yeah. And then don't you miss research? Because 10% doesn't sound like a lot.
No, I'm actually not very research driven. And I do have some clinical research, but again, that I usually do with other people as well. But no, I'm not a big research driven person. I've definitely found myself, I think, in the teaching.
Oh, cool.
Yeah, one of the great things about veterinary medicine, I think, is there's lots of ways to be a veterinarian, right? And if you can find your niche, and you're really lucky, right? Because you found that mix that works for you.
Yep.
So I think that's one of the things that vets should realize, right? Like not all veterinary medicine is circumscribed by being like a general practice vet. There's many ways to be a veterinarian.
1,001 ways.
There probably is if we counted them. Yeah, there really is. So it's,
Agreed.
if you're not happy with where you are, like start looking around, right? There may be other ways to be a vet. So.
Yeah.
And what is your favorite subject? We know, but
yeah.
we want you to say.
We want you to say. Well, we think we know.
Yeah, we
definitely.
hope we know.
To me, the two most important organs in the body are the kidneys. People make fun of me for that.
That's two already.
That's right. Yeah,
That's
exactly.
right,
Exactly. So the kidneys and probably the bladder being a distant second, but a close related cousin.
Yeah, cousin.
The bladder's related.
Exactly.
Because otherwise, without kidneys, what are we?
Exactly.
Yeah.
There you go.
What are we?
Yep. Agreed.
Yep.
That is true. That's true. We're lucky that we have two, though.
Yeah. We are lucky we have to.
Yeah,
Absolutely.
there's probably a reason.
Yeah.
But,
Yeah. So in feline medicine, of course, that's a big deal, right?
It is.
It's a really big deal. So all private practitioners know that the number of middle-aged and senior cats that are going to eventually struggle with chronic kidney disease is pretty big.
Right.
And I know you've been part of a recent guidelines group that's come up with some recommendations, which are fabulous, by the way. So I recommend them quite often. We'll put a link in on our website. We have purrpodcast.net is our website, and all our show notes go there. So I'll make sure there's a link there to the chronic kidney disease guidelines. And I love them because I think the group of people like you who put them together made sure they had a very practical bent to them. Yeah.
And that was truly our goal because I think for it to be adopted and understood, it has to be something that's easy to use and practical.
Yeah. We see a lot of guidelines, I think, that are like very academically oriented. They're very good literature reviews and they're very good like consensus, but it doesn't like come down the next step. Right. And say, okay, for you, Dr. Smith in practice in Aurelia, Ontario. How do I apply this? Right. So why don't we just talk a little bit about some of the things that are in the kidney disease guidelines that are really practical and useful. So in our favorite journal,
of course,
the Journal of Feline Medicine and Surgery.
We are really good in plugging.
I see that. That was pretty darn good. I was like, don't they know? I was like, wait a minute.
No, it's just another excuse to make sure we mention the Journal of Feline Medicine and Surgery. Yeah, and one of the great things about that journal, because it is the journal for both the American Association of Feline Practitioners and the International Society of Feline Medicine, is that any guidelines like that that we produce, as you know, are always available for free.
Right. Yeah. That's pretty awesome.
You don't have to be a member.
Fantastic.
Yeah. So I love that. And that's a way to get them widely distributed. Yeah.
Gotcha.
Yeah. So anyway, getting back to the kidney disease guidelines. So as you guys were putting those together, let's talk a little bit about sort of what your goals were and what you thought would be the most key practical types of things that you wanted practitioners to know.
Yep, for sure. So we looked at all the evidence out there, all the papers out there, all the research, and we tried to use really grades of evidence to make our hardest or more strongest recommendations. And where there was less evidence, we try to justify why something might be good or not good and why, but also to appreciate the clinical aspect of the patient. So for instance, grade 1 evidence, diet, that's not, the evidence is very clear. It's been shown multiple times.
Very solid.
So we made that that very clear where it's applicable also in chronic kidney disease. And so, that was a very easy section, I think, that we all agreed on.
And that's good that you say that, because you're with multiple people, and to get people to agree on one thing is already really, really tough and really good.
I've been on enough guidelines and consensus groups to know it's not easy.
It's not easy.
I think the one that showed me we talk about stones tomorrow, and we have the ACVM guidelines on stones.
Yes.
And you read in those guidelines the tension.
You feel it
between
right?
certain people that we obviously know.
Right.
That it's very funny.
But it's the nature of the beast, because we don't always have enough evidence.
Right.
And we all come with our own individual patient population experience to the table, which mine might not be exactly the same as yours, right? So I think this is natural. But the magic is trying to get to a core consensus on things, right?
No, it was a fun group to work with. I think it was a lot of fun, and the consensus came out really well. And there was not so much of that.
That's good. That's good. So you all felt pretty coherent.
Absolutely.
Yeah. So diet, best evidence we have for diet.
Absolutely.
So as we start going down from there, so what other things are like immediately useful to the practitioner.
Certainly proteinuria and hypertension, so substaging, looking at iris, obviously following those guidelines, and looking for proteinuria and hypertension, screening for those, not waiting for them to appear.
Oh, that's so important, right? You know, if we wait for them to appear, which is, I think, a bit of a default attitude, right? Yeah. We're not going to do our patients as much good. And especially for things like hypertension, you know, your typical silent killer. Yes. Right? Exactly. You got to go looking for it. That's a really good message. Yep.
And same for proteinuria, definitely a silent killer. And you know, by the time it becomes a problem, it's already
you're already you're already working.
Was there consensus on how you diagnose them?
Using the urine protein creatinine ratio.
Okay, so that's for the
proteinuria.
For the proteinuria, hypertension. Hypertension, if I'm not mistaken, above 160. It becomes problematic. But I think we're all starting as a profession to look at that and wonder if the 160s are a true barrier, because I know in humans, if I'm not mistaken, they're looking at it way earlier as a risk factor. Exactly.
Yeah, and we've even seen with the latest hypertension, classifications. We've got that, a pre-hypertension in there now,
pre-hypertension,
right? Because it's kind of pushing our boundaries back further. Yeah. And I wouldn't be surprised if that gets pushed back even further, right? Because you start looking at, there's a few, and you would know this better than me, there's a few studies looking at cats like in, not necessarily in home environments, but at least in where they're not being handled every day to get blood pressure, like telemetry studies and that. Yes. Those guys are pretty low. Right. They're walking around at like 110.
Right, which is crazy.
Yeah.
For a cat.
Yeah, exactly. So you start to say we treat at 160, like, it's a big gap.
Yeah.
I think general vets struggle with doing correct type of, blood pressure measurement. Can you help them a little bit?
It's definitely stressful, especially for a feline population, right? I mean, to try to reduce that anxiety is certainly going to be key.
Yeah, we have anxiety. The cat has
anxiety. So of course, removing the white coat, trying to maybe get the blood pressures first thing you do in the room, trying to get blood pressures at home. I know some people have done that with pet maps, for instance. I'm sure you have more.
We do a lot of house calls for them.
Calls, right? Yep. There you go. Yeah.
And
what's your preferred method that you use?
So in cats, and again, you can correct me if I'm wrong, I think the consensus, we don't have great data to know what's the best. We don't. But I think probably most commonly would either be a Doppler or an HDO high definition
oscillometric.
Yeah. I trip over that word every time. Yeah. High definition.
It's amazing
oscillometric.
I did it. French is my first language. So.
Yeah. So it's a toughie. Yeah. So I think isn't that kind of the consensus? Like those would be the best in cats.
Yeah. Exactly.
The smaller patient always a little harder to.
Right.
Yeah.
Exactly.
Harder to do.
Yep.
But there's great equipment available now, more than ever.
There is. And I think people are taking blood pressures a lot more versus, maybe 20, 25 years ago, people may not have had a Doppler in their practice, right? They had an SpO2 monitor, didn't have Dopplers, didn't have oscillometric techniques. No. So certainly, proteinuria, hypertension, substaging, very important things.
Yeah.
Good.
Yeah. And it's also probably important for us to mention that since we're talking about iris staging, that it is not a diagnostic tool.
No, thank you. Yeah. And that when I lecture, I always remind people to first diagnose chronic kidney disease. And how do you do that? Yeah. Well, you need evidence, of course, of azotemia that is chronic and that it's the kidney's fault or mostly the kidney's fault. In other words, ruling out those ureteral lifts and ureteral strictures or post-renal causes.
Yes. So I'm guessing, like me, you're a fan of getting at least one set of radiographs.
Oh, absolutely. Oh, yeah. And that's what I recommend is when you have azotemia in a cat, last thing you want to do is put on blinders and say it is chronic kidney disease. Because that cat that has ureteral lifts isn't going to follow that iris staging after. It's not going to respond potentially to the same treatments or do as well, which, is going to be, unfortunate for the cat and the owners.
Yeah, because you've missed the real problem.
Exactly.
And it's getting, it's not necessarily readily available to everybody, but it's getting easier to deal with ureteral lifts. Certainly than it, was 10 or 15 years ago, right? There's more and more people doing like subs and stents and things like that, right?
So it is blood work, urinalysis, radiographs, anything else?
Bloodwork, urinalysis, radiographs, I would say is a great start. And urine protein creatinine ratio and blood pressure would be some of the things I would recommend.
Yeah.
Okay. Yep.
Cool. Yeah. Let's talk about proteinuria a little bit more because I think there's a little bit of controversy. I don't know about on the D side, but on the cat side, it's like, when do you start treating? And I have a little bit of a difference of opinion with published guidelines who want you to wait until they're at 0.4, and I'm uncomfortable with that. How do you feel about that?
We're on the same page.
Yay!
That's our high five.
Okay.
And so,
I think right here. Let's write it down.
I think there's at least 2 papers that show that a UPC above 0.2 could be problematic for those kidneys.
Mm-hmm. Yeah.
Now, there's also I think some people that promote just starting ACE inhibitors or ARBs, angiotensin receptor blockers, right off the bat for chronic kidney disease. I'm not quite sure what the evidence is for that, and I am worried about that. I don't know what your thoughts are.
Yeah, I think it's I think it's a bit too soon, and it's a cat. Yeah, right. Why give them a pill they don't necessarily need?
Exactly. Yeah,
that's it. So,
I like my fingers is really what it comes down to. And,
and you want the human-animal bond to be preserved.
Yes.
Right?
Yeah.
So we have to be quite humane.
Yep.
These renal patients can end up on like so many meds if you're not careful.
Exactly. What I call the renal aid kit, right?
Oh, I've heard you say that. I love that.
We tend to sometimes we want to help that patient, and we bring out the bag of renal aid kit that has subcu fluids, phosphorus binders, antacids, which I'm sure we'll talk about. Good. Phosphorus, just 6 different things. That owner's going to come back in a week either to euthanize that pet or won't
give
come
it all
back,
and then they're never going to see you again. They're just going to take their chances and leave the kitty alone.
Yep.
Yeah. So that's the art of veterinary medicine, isn't it? It's knowing what's the best for that patient.
Yep.
And I think it's also a big shout out to companies that we need to look at different routes. I mean, it's not all through the oral cavity.
That's true.
Right.
Because that's probably the worst route in the cat. So let's look at other routes. And I think some of the companies are picking it up with some of the products that we're getting. Right. So that's fantastic.
Yep.
Agreed.
But that's something that we really need to focus on a little bit more because polypharmacy in the cat doesn't work.
No.
Correct.
I mean, that's the whole
Agreed.
idea.
100%.
Yeah. So I'm glad we're on the same page, and you're not going to wait till they're all like 0.4.
No.
Yeah, I'm happy at once. Cats don't commonly get proteinuric anyway.
Exactly.
Right? Like they're not a great species.
I think less than
right?
50%.
Yeah. So when you start to see them be proteinuric, and it's a quiet sediment, it's not lower urinary tract.
Yep.
I mean, that's not normal anyway, right?
But I think that this is the whole discussion because if you have cats in early stage renal disease, so that's stage 1.
Yes.
I mean, should you already get worried? I mean, we have a lot of the discussion that we have because, do you want to switch them over into diet change? Do you want to switch them over while they're already really sick and they don't want to eat anymore? Yep. Or do you want to do it in the period that they're still happy?
Is this a big unanswered question? So I'm interested to see, what do you say about diet therapy and when?
I'm excited that stage 1 is no longer a mystery. Put it that way, right?
Yeah, because it's always been like, what do we do with that?
It's like, who cares about stage 1? Even the old Irish guidelines, I remember, I have a picture of them. Stage 1 had not even a line. It just said monitor. And then stage 2 had more recommendations. Stage 3. Now, if you look at the Irish guidelines, stage 1 is actually the longest in the column. Why? Because now that we can actually diagnose them with our earlier biomarkers, we can potentially not only screen for proteinuria hypertension, but look at some new treatments. Maybe early stage kidney diets, for instance, or geriatric diets might be more appropriate, more moderate phosphorus. So I think it just really breaks our paradigm about what stage 1 is and what we can do with it.
Yeah, I'm glad you mentioned that because it seemed kind of like, why do we even have a stage 1 if we're not going to do anything about it? But they're and it's concurrent with the fact that we are seeing companies make early stage renal diets, which we never had. They have a broader array of dietary tools now.
Exactly.
That we never had before. So
and I think also you need to be a little bit more careful with concurrent diseases and how you treat those animals because they are at risk. So why would you do exactly the same that you always did with a case that's at risk?
Thank you. That's perfect. Then if you have a stage 1 patient, you'll be a little more careful with anesthesia, medications, you'll monitor them a little more. We know that stage 1's not benign. 30% of cats in stage 1 will go to stage 2 within a year.
Wow.
That's not benign.
No.
And those cats are already losing weight. A study out of Tufts showed that. A lot of cats are already losing weight a year before.
That's true.
Exactly.
Yeah, it's like the earliest biomarker, isn't it?
Exactly.
Unexplained weight loss.
Exactly. Even though stage 1 has been a mystery that is benign, it's not benign.
Not benign.
So I'm happy that we're doing a lot of research in this and being proactive.
Oh, I love the way you phrase that. Yeah. We really need to empower veterinarians to intervene early because I think they've been worried, and plus, up until now, we've been told there's no benefit to starting a cat on a renal diet before it has chronic kidney disease.
Right.
But we weren't diagnosing it till late anyway.
That was the problem.
Yeah.
Yep.
It's 75%.
Yeah.
Yep.
So, I mean, it's crazy.
Mid-stage 2. That's where we would get some.
Yeah. So it's really backing that up. Yeah.
Yep.
So thank you for a wonderful first part of a Purr podcast talking about renal disease in cats.
It goes so fast. I'm glad we're going to have another time to talk to you.
So
absolutely.
We'll be talking about a lot of other things still in our second part, which is in 2 weeks.
Yep, including how we take care of the late stage cats and what we can tell owners about that. So
sounds awesome. Thank you.
So thank you so much.
Thank you.
Dr. Susan Little is a feline medicine specialist with 2 cat-only hospitals in Ottawa, Canada. She is best known as an international speaker and as the author and editor of 2 textbooks, The Cat, Clinical Medicine and Management, and August, Consultations in Feline Internal Medicine. Along with 3 cats, she also admits to owning 2 dogs, and you can follow her on social media with the handle @CatVetSusan. Dr. Jolle Kirpenstein is a diplomat of the American and European College of Veterinary Surgeons and a big cat fan. His specialties range from surgical oncology and reconstruction to minimally invasive surgery. He is the author of 2 textbooks on basic and reconstructive surgery. Did you know he was allergic to cats? Jolle works currently at Hills Pet Nutrition. You can follow him on social media with the handle @GVETSX. The opinions of this podcast are those by Dr. Susan Little and Dr. Jolle Kirpenstein. Veterinary medicine is a complex profession, and often there are multiple diagnostic and therapeutic options for different disease processes. If you're a pet owner with questions, please go to your local veterinarian. If you're a veterinary professional, ask your questions on our Instagram page @Purr Podcast.